Today we're going to talk about ventilator management with a little bit of ABG interpretation thrown in. So let's just review some of the basics. From last month's lecture, we learned that we intubate patients if we have one of four potential problems: a failure to ventilate, a failure to oxygenate, a failure to maintain their airway, or they have an expected clinical course that would require an intubation. When determining how to appropriately ventilate our newly intubated patient, we need to ask ourselves, is this patient failing to ventilate, or is this patient failing to oxygenate? Because we've taken care of the other problems, right? Failure to maintain the airway, we took care of that with the intubation. Or expected clinical course, again, we're taking care of that with the intubation. So it really comes down to determining which of the two other things are we trying to fix: ventilation problem or an oxygenation problem. A patient with a failure to oxygenate is in a hypoxic respiratory failure. The body's unable to utilize the oxygen it has in an appropriate manner, or it's having trouble getting enough oxygen despite maximum supplemental oxygenation administration. Examples could include patients with a shunting problem, so like a pulmonary emboli blocking the ability to gas exchange, a dead space problem, like a pneumonia is filling alveoli with gunk so it can't exchange gases either, or hypoventilating patients. A patient with a failure to ventilate is in a hypercarbic respiratory failure. This is indicated by elevated levels of CO2 in the bloodstream, typically causing altered ventilation when it becomes critically high. It is frequently seen in patients with hypoventilation issues, neuromuscular disorders, drug-induced respiratory depression. In these situations, you want to assess the why and then treat. Failure to ventilate tends to be a symptom of a larger problem. It won't fully resolve until we fix that primary problem, right? So this is going to be an important concept that we're going to come back to in a little bit after we talk about the basics of the vent. All right, so in this example, I put up the servo I, so that's one of the most common hospital ventilators, but a lot of the other ventilators that we have in use that we see in transport, they follow the same basic principles. All right, so in the servo I specifically, you're gonna see that there's a mode, and we're gonna talk a little bit more about that as we move through this. Everything on the bottom portion of the screen are the things that we're setting, okay? So what you'll commonly hear if somebody gives a report, they're gonna say the respiratory rate, so they'll say 15 by 480 is often a respiratory rate of 15 by a tidal volume of 480. They'll say you've got a FiO2 of 40% and a peep of 5. All right, so these four things we essentially always set. We might not always set a tidal volume, we might set a pressure, and we're going to talk about that in a little bit, but respiratory rate, peep, and FiO2 all get set, and then either tidal volume or pressure setting. All right, so that's what we set on the ventilator. And what about all of the other numbers that you see? That's what the patient's doing. All right, so you can see here, we've got our PIP. We're going to talk about that more, peak inspiratory pressure. You can see the respiratory rate and the O2, and you would think, why are those there if they're here on the bottom? Well, because just because we set this doesn't mean it's actually getting this, right? So if we have a patient that's over breathing the ventilator, we may have it set that the respiratory rate is supposed to be 15, but this may actually read 20, 25, 30. It could read whatever the patient's actually over breathing. So you want to look to this to see what they're actually doing and look to this to see what you've set for them to do. You can also see down here, we've got some information. So your MVE, that's your minute ventilation. We're going to talk about that in a little bit. Your VTI and your VTE, that's your total volume inspiration and total volume and expiration. So these numbers should be pretty much the same because what goes in should come out, right? So these are all numbers that you're going to be seeing on whatever vent bed it is that you're working with for the most part. There's some very basic vents out there that are used in, say, like trauma management and some MCI situations. But typically, all of the vents out there are really pretty high level and give you a lot of information. So it's really important to remember what you're setting and asking the vent to do versus what the patient is actually doing. What about all of the different various vent settings that we have to choose from? So the first thing we're going to talk about is the targeted setting. So that's how the ventilator measures and delivers breaths. And there's two targeted settings that you could set on your ventilator, either volume or pressure. A volume targeted setting is being measured by exactly that, volume. The ventilator will fill the lungs with a set amount of volume that you program into the ventilator. The volume selected is determined by identifying the patient's ideal body weight and using the calculation formula of 4 to 8 mLs per kilo, ml being the volume of air per the ideal body weight in kilograms. Now, this setting can cause barotrauma, that overstretching and damaging of the alveoli, and increased lung pressures if administered in high amounts or if given inappropriate. That is why it's so important to use ideal body weight and not actual body weight. When you're in a volume targeted setting, you must monitor the peak inspiratory pressure, AKA your PIP. Now, if the PIP is high, and high we consider greater than 40, your volumes might be set too high. Consider decreasing the volume per breath. Never want to ignore an elevated PIP because that's your lungs' way of screaming out, this is too much for me to handle. Now, a pressure targeted setting is being measured by pressure, right? You will program the ventilator to provide a certain amount of pressure, and the ventilator will give volume until the lungs reach that preset pressure, and then it stops giving a breath. So unlike the volume setting, where the volume is fixed and the pressure is variable, in a pressure setting, the pressure is fixed and the volume is variable. You still want to calculate the ideal body weight so you can determine what an appropriate tidal volume should be so that you can assess your ventilator to ensure that you're giving enough pressure to actually allow the lungs to get enough volume. If your pressure setting is too low, it's not going to deliver enough volume for the lungs. And this setting is typically used for really poorly compliant lungs that are severely damaged, like patients with COVID or ARDS. So then we need to figure out what mode we want to be in. All right, so there's 3 conventional modes: assist control, SIMV, and pressure support. And while there are other ventilator modes, we're going to focus on assist control and SIMV for this lecture to understand the difference between those. We're not going to talk about pressure support, so it's typically used during more of your weaning phase when you're getting ready to try to move towards extubation. We're just not going to talk about it here in this lecture. But assist control and SIMV are the 2 that I really want to make sure people understand the difference. So in assist control, every breath given is exactly the same. The ventilator controls every breath in order to reach its targeted goal, whether you set that goal to be volume-based or pressure-based, every breath will be identical. If the patient does not trigger a breath, the ventilator will just deliver it at the preset rate that you put in, right? But if the patient does trigger a breath, that breath is going to be assisted to reach the set target, whether that was a set volume that you put in or a set pressure that you put in. So what does that mean? In the example on the screen here, you can see that every breath is the same sized waveform, indicating the ventilator is controlling every breath. Now, the first 2 breaths you can see here are initiated by the patient. We know that because we see this little downward spike here. So that's a patient-initiated breath versus here, you don't see that. That's a non-patient initiated breath. That's a ventilator breath. Now, the downside to assist control is that it is very uncomfortable for a lot of patients. The breaths are mandatory and are programmed, which can lead to vent dysynchrony if the patient is trying to breathe too often on their own. So this mode is really ideal for those that are heavily sedated or paralyzed, but it's not great for patients that aren't heavily sedated or paralyzed. Because if you think about it, if they try to take a breath a little early, it's forcing them to take a whole huge breath. So let's say that we set our ventilator to have a targeted tidal volume of 450. Now, every single breath that I take, it's forcing 450 mLs in. It's not allowing me to take a little mini breath in between. It's making me take the full volume every time. So it makes patients very uncomfortable. They do not tolerate this well if they're not heavily sedated or paralyzed. That's where SIMV comes in. SIMV is also called synchronized intermittent mandatory ventilation. And the ventilator has a set number of mandatory breaths with its target, so either that volume target or the pressure target. But the patient-triggered breaths aren't strictly controlled like an assist control. These patients' triggered breaths may be given some assistance in the form of a little pressure support, but without a specific target in the vent's mind. And this pressure support is different from targeted pressure control. The intermittent breaths that are supported by that little bit of pressure support work similar to how BiPAP works. It's just a little extra oomph given to those intermittent breaths. So in the example on the screen, you can see that the mandatory breaths are this first one and this third one, right? So you can see that these all look pretty similar. The first one and the third one look pretty similar, but the second one doesn't. It looks like they took 2 little mini breaths, right? And that's because in this mode, the patient can have these smaller mini breaths in between the mandatory breaths. So it leads the patient to be more comfortable if they're intermittently spontaneously breathing. And so that's why this is the mode that you're going to see most patients in most of the time, because it gives them a lot more control. And the ventilator is only there to really kick in and take over if they stop doing that independently on their own. So SIMV is really a great option. If a patient is heavily sedated or they're paralyzed and you have them in SIMV, it'll work identical to assist control. So they function the same when the patient's not doing anything. The difference is when the patient is somewhat awake and trying to take breaths on their own. SIMV is a significantly better option than assist control. Okay, what about our tidal volume? We need to set that. So the tidal volume is the amount of volume delivered with each breath, measured and calculated in mLs. If we're using a volume targeted setting, then we will set the tidal volume directly on the ventilator. If we choose a pressure targeted setting, then we're going to use this number as a goal when we're setting our pressure. So we would set our pressure hoping to achieve a tidal volume close to this. Now, the normal tidal volume in a healthy adult is anywhere from 4 to 8 mLs per kilo of ideal body weight. When coming up with a tidal volume for a newly intubated patient, we need to know their height to determine their ideal body weight. And a lot of ventilators actually have these charts so that you can quickly look on the female side and on the male side, see how tall they are, and then come across. And it'll tell you how many mLs it should be for 4 to 8 mLs. Now, do keep in mind that our alveoli are these sensitive little sacs that are used for oxygenation processing, right? If we damage them by hyperinflating them, giving too much volume, or hypoinflating them, causing atelectasis, we can actually worsen the problem. And that's why we try so hard to have a good targeted tidal volume. Now, I really like this picture, and this is a really great example of why utilizing ideal body weight is so important. So this patient was actually somebody that I had transported. She was about 120 kilos, 5 feet 2 inches tall, and she was being ventilated at 6 mLs per kilo of actual body weight. That ended up being about a volume of 720 mLs. It's way too much, right? Her peak inspiratory pressures, we're going to talk about those in a little bit, were well above 40. And 40 is that cutoff number where we need to be, I'm super worried that something bad is happening here, right? Because the excessive volume was causing excessive pressures. She wasn't being ventilated properly. Now, her ideal body weight using her height was 5 feet 2 inches was her height. So it was about 50 kilos, which equals a tidal volume of around 300 mLs. So once we drop that tidal volume down to the appropriate range, it's easier to ventilate, her SpO2 improved, her end tidal decreased, everything got better. So just remember, just because a patient's larger doesn't mean their lungs will be. And you can clearly see here that you can't guesstimate the size of somebody's lungs based off of the size of them. So please don't. Always measure their height, get a good number, and then come up with the ideal body weight and get your information from there. Okay, we're going to need to set a respiratory rate on our vent. The respiratory rate equals the number of breaths within 1 minute. Now, normal ranges are between 12 and 18, but severely acidotic patients might require respiratory rates of 20 to 30 or even higher to blow off the excess CO2 accumulating in the body. So here's an example of when you might see that. Let's say you have a septic patient being intubated for respiratory failure. They're breathing independently at a rate of 40 times a minute before intubation. After intubation, the respiratory therapist sets the patient's respiratory rate to 16 because 16 is normal, right? What's going to happen? Well, we'll talk about this a little bit more in the ABG section, but that patient has now cut the respiratory rate in half. Now, what happens when we breathe, when we exhale CO2, right? So if we exhale a lot, we're blowing off a lot of CO2. And if we exhale a little, we're blowing off a little CO2. So if I take somebody that's breathing 40 times a minute and I cut that down to 16, I went from breathing a lot and blowing off a lot of CO2 to breathing a little and blowing off only a little CO2. And if I'm not blowing it off, where is it? It's staying in the body. And it stays in the body, it starts to accumulate, it makes you more acidotic. And now you have a patient that is going to potentially code or peri-arrest because they've now become so acidotic because of that buildup of CO2 because they're no longer blowing it off. So normal isn't always correct, especially in really sick individuals. Normal vent settings are not always correct. And keep in mind that if your patient is spontaneously breathing, their actual respiratory rate might be higher than the respiratory rate that you set on your ventilator. So it's very easy to get into the wormhole of, oh, my end tidal is too low. And so I think I'm going to need to turn my respiratory rate down, right? Because if my end tidal is low, I'm breathing off too much CO2. So that means that I want to kind of slow my respiratory rate down to hold on to a little bit more CO2 so I'm not blowing so much off. Well, if your patient's spontaneously breathing over the vent, doesn't matter what you turn that number to on the vent. they're overbreathing. So the only thing that you can do in that situation is sedate them more to get that respiratory rate to actually fall in line with what the vent's trying to do. So lots of factors that go into this that can make it pretty complicated. All right, so what happens when we add tidal volume and our respiratory rate? What do those mean, right? Well, we don't actually want to add, we want to multiply. So minute ventilation, the tidal volume in mLs times your breathing rate per minute. That total is the amount of air moved in or out of the lungs in every minute. Normal minute ventilation is about 5 to 8 liters, but in your really sick and acidotic patients, you can need up to 15 to 20 liters per minute. There's a really important concept to understand here. If you change one of these factors, either the respiratory rate or the tidal volume, you will need to change the other factor to compensate. Let's pretend that you had a patient with elevated PIPs. So you decide to turn down your tidal volume because less volume in the lung equals less pressure. Okay? Because you turned down the tidal volume, the minute ventilation decreased as well. But we don't want that to happen. So that means you would need to turn up your respiratory rate. Examples of situations in which you might need a higher than normal minute ventilation include patients with severe metabolic acidosis, the DKA or aspirin overdoses, and severe respiratory acidosis. So just remember, if you change one of these things, it's going to change your minute ventilation. So you want to make sure that that equation balances out so that this remains consistent. Or change these things to help to increase or decrease your minute ventilation. So these work together. FiO2. So we've got to set some type of an FiO2. So normal atmospheric FiO2 is 21%. We can administer anywhere from 22 to 100% FiO2 with invasive ventilation. And you just want to keep it as low as you can while maintaining a safe FiO2 for that patient. How about our PEEP? All right, so what is PEEP? PEEP is positive end expiratory pressure. It maintains alveolar recruitment and optimizes the ability to provide effective oxygenation. What does that really mean though? So PEEP maintains the alveoli in an open state at the end of the expiration phase. It essentially doesn't let the alveolar sac state. This prevents the sac from collapsing on itself, sticking together, and then being damaged when it's reopened. It also increases the surface area of the alveoli, making it easier for the body to exchange oxygen and CO2. The more PEEP we give, the more the alveoli remain inflated. Okay, so you can see here in this example, this is no PEEP on inspiration. So you can see it kind of, the lungs puff up a little bit, but then on expiration, they totally flatten and crump again. And then puff up a little at inspiration, totally flatten and crump again. This is when we set a PEEP to 15. So now when we breathe, you can see that the lungs are actually getting bigger because when you take a breath in, it fills. But now when they take a breath out, instead of fully collapsing, some of these sacs are staying open. So now the lung tissue is actually staying bigger. So then you take a breath, and when you take a new breath, you actually get more of those sacs opening. Now this is showing PEEP at your 5th breath. So if we set a PEEP of 15, it's showing what several breaths will get you. So what happens with PEEP, and you can watch some really cool YouTube videos if you just Google PEEP in pig lungs even, what you can see is that when you actually first apply PEEP, for every breath it opens like a little, and then a little, and then a little, and more, and more, and more, until those lungs are fully expanded. So it takes a breath in, but when they breathe out, instead of totally collapsing, those little sacs all stay nice and open. So the lung fields stay nice and open. And so this is really important because it increases that surface area in which the oxygen exchange actually can occur to improve your oxygenation. All right, so your normal intrinsic PEEP, the PEEP that we have when we're sitting here just breathing and talking and doing our normal things, is anywhere from 3 to 5 centimeters of water. And there's always arguments about that. Some people say it's 0, but typically you say 3 to 5 is normal. Now on a ventilator, we typically set our PEEP anywhere from 5 to 20. And depending, in neonates and kids, it can be a little bit less than that, but typically 5 to 20 in adults. Now keep in mind that the PEEP we set will contribute to their overall peak inspiratory pressure. So if our PIP, our peak inspiratory pressure is 35, and we increase our PEEP by 5, our PIP will also increase by 5. What is our PIP? Okay, peak inspiratory pressure. So the peak inspiratory pressure isn't something that you set on the ventilator. It's an indicator of the overall lung function. Now the PIP is the highest pressure measured during the respiratory cycle and is a function of both the resistance of the airway. You can see here's the resistance of the airway and the compliance of the respiratory system, plus the PEEP that you set. Okay, this is the pressure that is generated by the ventilator to overcome both airway resistance and alveolar resistance. Now, there are several things that can cause an increased PEP. Increased secretions that are starting to block part of the passage of the ET tube, so we can section that out of the way, bronchospasms, biting on the tube or coughing, and decreased lung compliance. Now, the PIP should never be above 40 without attempts to try and bring it down. We either make some changes to our vent settings, better sedate our patient, use medications like albuterol to open up airway passages, or fully sedate and paralyze. Now, some patients, like your severe asthmatics and those with ARDS, might be above 40 despite maximum intervention. You still want to do the best that you can to bring that number as close to or below 40 as possible. The big takeaway point with PIPs, if your patient's consistently above 40, not just spiking up with coughing or sectioning, but at rest, consistently over 40, you want to let your provider and respiratory therapist know ASAP, because that's the lungs screaming, there's too much pressure in here, this is too terribly much, and I can't handle anymore. Now, our plateau pressure is also a part of this graph. So plateau pressure is also called P-plat, and it's something that you, again, don't set on the ventilator. The plateau pressure tells you about the patient's pulmonary compliance. Now, our goal is to have this number be less than 30. It's measured by applying a brief inspiratory pause after ventilation. So if the PIP is the highest pressure during inspiration, the P-plat is the pressure that remains in the lungs if you were to pause at the end of inspiration before you begin to exhale. This is the pressure that is essentially left over in the lung after the tidal volume has been delivered. So this is an important thing to understand, because you can have a really high peak pressure and a normal plateau pressure, okay? You can have both of these clearly be normal, and that's really our ideal world. You add in more PEEP to that ventilator setting, and now you're actually increasing our overall peak pressures because your PEEP is higher, and all of these accumulate and add together. So these can be some confusing topics if you don't actually get to see it on a patient on a vent. And so I would definitely recommend looking into it a little bit more so you can read more about these and ways that you can mitigate having these numbers be too high, because there's a lot of really interesting literature out there about this. But it is a good concept to be able to understand. All right, so how do we know what settings are actually best to use? So we talked about all the different aspects of it, right? But how do we actually know where to start or what to set people at? So the first thing that we need to do is determine our goal and determine if our patient is in a failure to ventilate situation or a failure to oxygenate situation. And then from there, we can figure out what the goal is. So when we have a patient that is a failure to ventilate, all right, there's two ways that we can affect ventilation. We have our tidal volume and we have our respiratory rate, okay? And that's really it. Those are really the two big things that affect our ventilation and our ability to control somebody's ventilation. So remember what those two things make up is your minute ventilation, right? So your minute ventilation is what helps to affect your overall ventilation. So these two settings are what you would manipulate to best treat your failure to ventilate patients. And how do you know if that strategy is actually working, right? You're going to assess your end tidal. It's the easiest way. You can also look at an ABG, and we're going to talk about ABGs in a little bit, but end tidal is something that we should have connected and should be continuously monitoring our patients. So end tidal CO2 continuous waveform capnography is the gold standard of ventilator management. It should be used on all of our intubated patients, and it'll help you better manage your ventilator to give better care to your patient. So a normal end tidal is about 35 to 45 in a normal, healthy adult. So keep that in mind as I keep talking, okay? So higher than 45 usually indicates that there is retention occurring. And we end up increasing our minute ventilation by either increasing our tidal volume or increasing our respiratory rate, or maybe even both, right? Because like we talked about before, CO2, when you breathe more, you blow out more. So if our end tidal CO2 is high, we want to blow some of that off. We want to get it out of the body. The only way to blow it off is to blow more. And so that's why we increase our tidal volume or our respiratory rate. Now, lower than 35 in a normal healthy person usually indicates that we're offloading too much. So we're breathing too much. Our minute ventilation is too high and we're offloading too much CO2. All right. So here's the big caveat. This is why I kept saying in healthy patients. In really deranged patients, so our really metabolically acidotic patients, it may be okay to have an end tidal well below 35. All right. So let's think about it this way. Let's say we have a tachypnic patient that has metabolic acidosis. So let's say it's like a DKA patient, right? And their pH is like 6.9, 7, it's terrible. You end up intubating them for whatever reason, because intubating a DKA person is not always the best idea unless you absolutely have to, because they're very difficult to manage on the ventilator. And so it's a totally different topic to talk about. But let's say you decided to intubate them and their opening end tidal is 18. Okay. They were chugging along, breathing, forget what I might have just said, 40, 50 times a minute, and their end tidal is 18. All right. You're not going to allow that end tidal to come up to 35 to 45 and be normal, right? Because that's going to make that person retain more CO2, which is going to worsen their pH, and they will code within, 15 to 30 minutes, depending on how severely you cut down their minute ventilation. So whatever their initial end tidal was, they were breathing really fast on their own, blowing off as much CO2 as possible to try to keep themselves essentially from coding, to try to get that pH up as much as they can, because the metabolic derangement was so severe that the kidneys can't do anything to help out. So it's just the respiratory system. So they're doing everything that they can to try to blow off as much CO2 to try to improve the acidosis as much as possible. If you don't continue that, acidosis gets worse and then they end up dying. And so it's a really important concept, I think, to understand that normal is not normal for all patients. So normal is normal for healthy, normal patients, but normal can be actually really abnormal for your really sick patients. The other thing that I want to just throw in there, because I try to do this as often as I can, is talking about bicarb, right? And so in these situations, when we administer bicarb, but we're not appropriately ventilating, and so what you'll see actually is bicarb, and they've talked about this more in an ABG lecture that I did before, and so it's on the YouTube channel. So if you haven't done much with ABGs, I would recommend you watch that one. But bicarb actually converts pretty quickly into CO2 and water, and so when you give bicarb, you're just quickly converting most of it, not all of it. Some of it will get absorbed by the body and utilized in that way, but a decent amount is going to get converted right back to CO2. And so if you're not ventilating that patient well enough, you're actually making the problem worse. And so what you can see is after giving bicarb, you'll actually see an increase in the end tidal CO2 because of the more available CO2 that's now in the system that now you have to try to offload on top of everything else you were trying to offload, which is why blindly giving bicarb is not a good decision. All right, how do we manage a failure to oxygenate? So there's only two ways to affect our oxygenation, our FiO2 and our PEEP. So it works out pretty simply, where if you want to affect ventilation, it's tidal volume or respiratory rate. If you want to affect oxygenation, it's FiO2 or PEEP. It's a pretty simple way of looking at it. Increasing the FiO2 increases the amount of available oxygen molecules for the body to use. Increasing the PEEP helps the alveoli open, which increases the amount of surface area between the alveoli and the capillary membranes for oxygen to be able to transport across. So if you use something like an ARDSNet table, this is one that's been super popular, especially with COVID, because we see a lot of our COVID patients develop ARDS. You can actually see a stepwise increase in both FiO2 and PEEP help patients better oxygenate. So what it does is, rather than just going straight to 100% on your FiO2 and a PEEP of 5, which you see almost consistently on every newly intubated patient, it actually kind of has you stepwise up and say, okay, if I'm at a PEEP of 8 and 50% FiO2, the next step, if I'm still hypoxic, or if I haven't reached my goal, is to then step up on my PEEP. I'm going to increase my PEEP. Now that I've done that, I'm going to step up on my FiO2 and kind of work your way stepwise up there. And it does work very nicely. So how do I know if my strategy is working for my failure to oxygenate patient? Well, your SpO2 and your PaO2 should start to improve. And using both the SpO2 probe and the PaO2 on the ABG will help you guide you in determining if your oxygenation strategy is working. And from here, you can actually look at your PF ratio as well. That's getting a little bit more advanced, but I would definitely, if you're interested in this, go ahead and look up PF ratio and learn a little bit more about it, because that's even going to give you more information about what your oxygenation status is. Okay, so let's say my vent's not stopping alarming and nobody's around, and what do I do? So the dope mnemonic helps you to remember the most common causes and complications of post-intubation hypoxia or deterioration. It doesn't even need to be immediately post-intubation. This can happen days after. I mean, I went through the dope mnemonic, several times when I was in the ICU with patients that have been intubated for many days. So first thing that you want to do, dislodge or displace tube. Check your ET tube. See if it's still at the same depth? Is it in the same place? Could it have moved? Could it have dislodged? Could it have, gone right main stem or left main stem or gotten pulled out and now is esophageal? So check out that tube. And that's why it's so important to always know where your tube is secured. All right. O is obstruction of tube. So look at the tube. Is there any obstruction that you can actually see yourself? So the tubes, especially the longer that they've been in place, can become a little soft and actually bend at the lip and kink itself off. And that can cause an elevated PIP on your ventilator. A patient biting the tube would have the same effect because it's decompressing the diameter of the tube internally. And so it's actually causing a higher, the vent thinks that there's some type of an obstruction that's causing really high pressure. It can't get past, and it's because the patient's biting on the tube or they're coughing. Consider a mucus plug. Could there be something further down the tube that you can't actually see that could be impeding the easy, smooth airflow? So those are all things that we would need to consider. Pneumothorax. So a sudden or worsening pneumothorax can cause a sudden spike in your PIPs and P-plots and cause significant alarming. You'll also see changes in your vitals depending on the severity, right? Tachycardia, hypotension, hypoxia. Listen to your patient, assess their chest rise. If you have time to get a chest x-ray, then great. You can kind of assess the situation if the patient's stable enough to be able to do something like that. Otherwise, you can consider a needle decompression if your differential is high enough that this is indeed pneumothorax. And then finally, the equipment. Assess the equipment. It's not perfect. Sometimes there are things that get disconnected or malfunction. I had a couple of times, if too much water pooled in the corrugated vent tubing along the bottom, it can cause an alarm. So start at the patient and work your way back towards the vent. If you can't quickly figure it out, but the patient's in extremis, so let's say they became suddenly hypoxic and the event's alarming, saying that there's a malfunction or there's a problem, and you've checked through the rest of your dope, and you're like, my tube's in the right place, there's no obstruction, they don't have a pneumothorax, I don't know what the problem is. Then consider taking the patient off the vent and manually bagging until somebody arrives to help you troubleshoot the ventilator. Don't just leave them on it if they are actively in extremis and you think that the reason is because of the vent. All right, so there is a lecture, I think I mentioned this earlier, there's a lecture on ABG interpretation, going through a lot of the background information and how to read an ABG, examples of the 4 major disturbances that we see, so metabolic acidosis, metabolic alkalosis, respiratory acidosis, alkalosis. I would highly recommend watching that if ABGs are a newer concept too, or if it's something that you still kind of struggle with, because I found for me, until I was routinely reading ABGs and interpreting them, it was really difficult for me to sit through a lecture and I would kind of follow it along, but then I wouldn't retain it. And it wasn't until I actually started like probably annoying the respiratory therapist that I was working with by being like, hey, can I see your gas? Hey, can I see your gas? Because it was the only way that I could truly learn the information was to repetitively try to put it into practice. Now, in this lecture I'm doing right now, we're just going to review a patient on a vent and determine how to make appropriate changes to our vent based off of the help with the ABG. So I'm not going to go into all of that background information. So like I said, if that's something that you're interested in, definitely watch the other video because it's full of a lot of information about ABGs. All right, so let's pretend we have a recently intubated patient. The vent is set for a respiratory rate of 15, tidal volume of 480, and that's based off of 7 mLs per kilo of the ideal body weight. So we know that that number is safe and appropriate. FiO2 is set at 40% and your PEEP is 5. So what do we see with our gas? Well, we have a respiratory acidosis without any compensation from the kidneys, right? Our pH is low, our PaO2 is high, we're moving in opposite directions. We know it's a respiratory problem. pH being low, we know it's an acidosis problem, and bicarb not being involved at all because bicarb's normal. We know kidneys aren't functioning, so it's totally uncompensated. So we have an uncompensated respiratory acidosis. Our PaO2 is 68. So that tells us that we also have an oxygenation problem on top of our ventilation problem. We know we have a ventilation problem because we're in uncompensated respiratory acidosis, but we also have an oxygenation problem. So I don't know if you remember, we went over this a little bit in the ABG lecture. Normal PaO2 is between 70 to 100 when a patient is at 21% FiO2. But if a patient's not on 21% FiO2, you actually want to multiply the FiO2 times 5 to see what the normal would be at that elevated FiO2 setting. So, for example, if a patient's at 40% FiO2, we would consider a normal PaO2 should be around 200. Clearly, this is not around 200, 68. So we have 2 problems. We have a ventilation problem and we have an oxygenation problem. So let's figure out how we can work through this. All right, so our pH is too low and our PaCO2 is too high, telling us that we're not offloading enough CO2. We're not blowing off enough CO2. So what do we do when we have a ventilation problem and we want to address it? We have two options. We either change our tidal volume or we change our respiratory rate. So by increasing one or both of these things, we're going to increase our minute ventilation to blow off more CO2. But how do you know what to increase? So let's look up at our PIP. So our PIP is 39, which is right at the cutoff of where we start to get worried about lung damage from excess pressure, right? Because we want us to keep it below 40. So if we increase our tidal volume, it's probably not the best idea in this patient, because increasing the tidal volume will likely increase the pressure. If we add more volume to an enclosed space, there's going to be more pressure, right? So that makes sense. So it's going to be the safer option in this patient to increase the respiratory rate and reassess and see if by increasing the respiratory rate, we can blow off more CO2, but not cause a pressure problem. All right, we know our PaO2 is too low. So that's telling us there's an oxygenation problem somewhere. What can we do? So there's the two things you can do for oxygenation problems, right? You either change your FiO2 or you change your PEEP. And how do we know what the best option here is? Well, for this patient, increasing our PEEP is guaranteed to increase our PIP. Remember that chart from earlier where anytime that you add in PEEP, it contributes to the overall PIP? So in this case, it's actually safer to only increase the FiO2 and reassess. Now, what would happen if you turned up your FiO2 and maybe you end up getting all the way to 100%? You're still not getting improvement in your PaO2. You might be forced to increase the PEEP, but that would mean that you would need to mitigate the already high peak inspiratory pressure by either turning down your tidal volume. But keep in mind, if you turn down your tidal volume, you're going to have to turn the respiratory rate up even higher to keep that minute ventilation the same. Or you could try medications such as albuterol or sedation and paralytics to relieve some of the pressure in the lungs. It's definitely a balancing act. To fix one problem, you might cause another. So in closing, the best thing you can do for your patient on a vent is to be thoughtful about your strategy, frequently reassess to see if it's working. Don't assume that putting in normal vent settings will work on all patients. Normal vent settings work in normal patients, in normal lungs. Okay, abnormal lungs are going to mean abnormal vent settings. And you just have to be able to be thoughtful enough to work through the process to see how abnormal are they really going to be and is it benefiting the patient. So assess and reassess over and over again and continue doing that until they get to the point where they end up extubated. All right, guys, thanks for watching. And if you have any questions, just feel free to reach out to me anytime.